I'd like to introduce Dr. Withers. Dr. Jim Withers is the medical director and founder of Pittsburgh Mercy's Operation Safety Net and the Street Medicine Institute. He is an assistant clinical professor of medicine at the University of Pittsburgh and a member of the teaching faculty at UPMC Mercy Hospital in the Department of Medicine. In 1992, in an effort to create a new transformational classroom for medical trainees, he began to dress as a homeless person and make nighttime visits to the unsheltered homeless of Pittsburgh. In time, this evolved into a healthcare delivery model that not only provided direct care, but also coordinated the medical and social services for this population throughout the city of Pittsburgh. Since 1993, Dr. Withers has made extensive travels throughout the world to promote the new field he named street medicine. And in 2005, he created the annual International Street Medicine Symposium to support the global street medicine movement. Currently, there's over 200 street medicine programs on 6 continents. In 2009, he and others created the Street Medicine Institute to further support and develop the field of street medicine. And most recently, Dr. Withers launched the first Street Medicine Fellowship at the University of Pittsburgh Medical Center's Mercy Hospital. Dr. Withers, thank you so much for joining us today.
It's an honor and a delight to be able to speak with you all. I understand it's a very rich group of community members, folks from all sectors. Thank you very much. I wanted to talk about how I got involved with this and why, and then I'm hoping that we'll be able to discuss how you see this maybe applying to the terrain of your own city. The title, Go to the People, is a phrase that I saw on a wall in a hospital in Haiti. I'll get back to that in a little while, but it was from Lao Tzu. And those 4 words to me encapsulate not just the work of street medicine, but I think where we need to go in terms of healthcare and other human services. Too many times there's a disconnect between the reality of systems and the reality of individuals. Either folks who are within our system that we're not honoring their reality and finding ways to connect, or people that are excluded and not even showing up. The title is, I think, very meaningful to me. The image here happens to be me early on, but it also is a symbolic image that I've seen many times in my years of working on the streets and elsewhere. More often than not, a nurse will be serving people in this way, but I like the symbolism, and we'll talk about that a little bit later. So this is the real Dr. Withers. This is my dad. He was a family doctor, and I grew up making house calls with him in rural Pennsylvania. As a family, my mother was a nurse. We went to Central America and we worked, and it was transformational for me to be able to see the health and the social aspects of other people, either in these house calls or overseas. To me, it's very integrated into the notion of healthcare, is to not just practice from our point of view, but to try to make the journey into the reality of others. This is a slide I used to use for my lectures on domestic violence and intimate partner abuse. The issues that we typically look at medically, the hypertension, the diabetes, the psychiatric illnesses, et cetera, drug and alcohol use, we might chase each one of those, but if we don't recognize that the gravitational mass for a person may be very different than what we can perceive, then I don't think we have an accurate view of the people that we're trying to serve. In the early 90s, I had, unfortunately, a patient come into the hospital in the winter, and he was experiencing homelessness. He was an older guy that I didn't know, and within a day, he decided he had to leave the hospital, and I couldn't convince him to stay. He went out into a blizzard, pretty much, and I learned later that he had frozen to death. And as much as I like international work, and I highly recommend it, I realized that the lessons that I needed to learn might be under the bridges of my own city. And so I dedicated myself to finding a way to go out and to work with people, or get to know people, at least, I should say, who were living in this environment. For any endeavor you do, it's always good to do your research, find out who's doing what, get a couple notebooks and make notes. But ultimately, you're going to need to know people that are already trusted. In my case, it was Mike here. Mike had been homeless himself and was going out to bring people food and material goods. And I asked him if I could come along, and he said, well, I don't know. They don't like doctors. Well, I understand that, but I really want to do this. So he said, I'll take you out on 2 conditions. You don't dress like a doctor and you don't act like a jerk. He used a stronger word. I went to the local library and I found a book that actually described how one might dress to blend in with those experiencing homelessness. I showed up and Mike said, well, you've got the look at least. Let's see if you can keep up. And so I began to do what I'd call a pilot study, sneaking out at night with Mike after hours to visit homeless camps and places that he knew and the people there trusted him. I started off just being Mike's friend. And pretty soon, though, I realized that there was a lot of very ill people, people with desperate medical needs, isolated, people who would rather die than go to a hospital because of their previous trauma histories and such. So I began to try to practice medicine in the field. I didn't tell my boss, I didn't tell my malpractice carrier at this point. I just couldn't not try to do something with the folks that I saw. I had to start keeping records. They were kind of unusual because they were based on locations and aliases and nicknames and tattoos and things. And pretty soon I realized I was practicing medicine. The folks who are out there are really living in an excluded reality. Folks who experienced leprosy in the bygone eras and even now were the closest population that I knew that was as ostracized and judged as the folks that were sleeping outdoors. This picture always speaks to me from the point of view of the combination of how health issues can lead to losing your housing, losing your income, eventually losing any supports that you have. It does tend to affect folks who have had trauma histories, mental health challenges, and always the minority, the people of color, are overrepresented in the homeless population, and also even more so in the street homeless population. I made a visit to Minneapolis a couple times, and I realized the predominance of Native American folks out there. Here we have over 50% African Americans on our streets, but certainly that doesn't represent the population size, so they're disproportionately represented. If you're talking about folks who are experiencing homelessness, it's good to keep in mind, this is the work of Dennis Culhane in Philadelphia, that the majority of folks who experience homelessness are only really in that situation for a shorter period of time. The 10% who tend to be folks experiencing chronic homelessness and are more likely to be on the street suffer more, and they use more of assistance resources as well. As I got into the street world, it reminded me of early work I had done with domestic violence, in which I began from a framework of empathy, sympathy, what can I do? And after a while, I realized the strengths and the resiliency of the folks that I was working with were as important or were more important than the perceived pathologies and challenges that they had. And I realized on the street, a lot of folks, I could never live like they did. I would give up. So I began to see the strengths of folks like Tracy here. I like this photo because the little girl represents, for me, the child that can still see another human being that's suffering. So I suggest that we should keep that inner child in us to see the human being in front of us. People who are experiencing street homelessness find support systems that are there for them. They have fierce loyalties. They may seem dysfunctional to us, and they can be, but it's kind of like people who've been in a war. The folks that were in the trenches with them are the only people that they really believe will understand their stories or can share it. When you ask people to come off the street and do something else, there's an awful lot of reluctance to leave the people that they know, the situation they're used to. And a lot of times it's similar to domestic violence, I think. Folks have stopped believing that they're capable of making that journey to another reality. There's often a lot of shame imposed by society and then internalized. And so you're starting at a place with folks that's really in need of deep affirmation, unconditional regard, harm reduction, love, consistency, things that are really the platform for healing. I think that's true of all of our healthcare encounters, but on the street, you're really forced to engage in that kind of relationship building and those values, or you can't get anywhere with the folks on the street. And that's one of the things that I really appreciate about my friends out there. As much as people told me that they'd rather die than go to the hospital, and how much they hated those of us in the medical field, having a physician coming to them, and then shortly thereafter nurses, was so powerful for them. I remember one gentleman on the riverbank who was staring at me working with somebody, and he just started sobbing. And I said, well, why are you crying? And he says, I can't believe someone cares that we still exist. And so, as Danny said, one of our formerly homeless workers, it ain't hard to go out there. It's hard going home when you know people are still sleeping out there. And so once I got accepted as Doc Jim and people began making referrals from one bridge to another, I knew that I couldn't turn my back on these people, and that I had an opportunity and a moral obligation to try to be there for them. So I had to make it up as I went. At the time, I hadn't heard of anybody else doing this kind of work. I had a background in wilderness medicine, which is handy. And so I began putting medicines and things into a backpack, and off we went. Here we were in the early days treating a guy who had frostbite. He'd had repeated admissions for bone infections of his feet. And here we are just sort of chase managing him, is what we call it, until those feet healed up and actually saved the health system a lot of money. But meeting people where they were, rather than waiting until there was a crisis or even death, just seemed to be the right thing to do. In this photo, I'm leaving a message for somebody. I called his primary care doctor who hadn't seen him for a while. He said, sure, I'll see Mark. He's a great guy. And so I'm here under a bridge writing, Dear Mark, your doctor will see you Thursday at 2:00. And I realized at this point that we'd become a home care service for folks that were experiencing homelessness. The bridge in the background for me symbolizes the connection between the street reality and all those services and resources that people on the street needed. It was an epiphany moment, because I realized if you have a good program like this, you have a continuity of care. You have people that are trusted by the folks on the street. They can call you if you have a number that's available. We had an answering service at 3 a.m. You could get a call from somebody who's frightened. At 4 a.m, you can get a call from the emergency room saying, there's a guy here whose name is Spike. He won't tell us his real name. Oh, Spike, he's allergic to penicillin. We'll follow up tomorrow and try to get him into the wound clinic. And so you never really had to theoretically drop the ball with this population that is otherwise really hard to have any kind of continuity with. And at that point, I thought, this is like a new thing, like a fire department. It doesn't have a name, but every city that has folks on the street should have one of these organizations. And so we were able to get a program, Operation Safety Net, thanks to the Sisters of Mercy and a Care for the Poor grant that got us started. And we had an office, and folks like Kenny here could come, not ready for prime time, but always welcome. We got a staff that 3 of those guys were formerly homeless and a larger volunteer pool. And we were off to the races in 1993. We began realizing the importance of bringing social workers out to help people navigate things from their campsites to get into housing and rehab services. We developed an electronic record system back in 92, way before the hospital, which was able to coordinate our care. And it was just so much fun inventing a system that actually served people instead of having to fit people into a system that wouldn't necessarily serve them. We take care when it's needed. This is one of our residents. We're draining an abscess in a woman who was terrified to go to the hospital, but had an abscess in her arm. And we were able to take care of this, pack it. It healed up well. And eventually we were fortunately able to get this person into housing. Real quick, for those that are interested in some of the stats, there's not too much that really focuses on street medicine because we're a new field of medicine, but it's coming. But most of the folks on the street have traditionally used the emergency room. So if you can make a partnership with your local safety net hospital, there's a really win-win situation between street medicine and those hospitals where unsheltered homeless people use the emergency rooms far more than the general population. You can see different ways of looking at that. At our hospital in Pittsburgh, I looked at it and realized a third of the highest utilizers were in my street population. They also have longer length of stays in the hospital and readmission rates. Folks experiencing homelessness go through a number of settings, not just the streets. And by having a team that's fluid, almost like a medical home model, where no matter where you go, there we are, a street medicine team can really pull this care together. One of the things I did with domestic violence back in the 80s, which I felt was really important, was creating a consult service for intimate partner violence. Street medicine consultation services are a key cornerstone of any good street medicine program, where you go into the hospitals and you help the patient navigate the system. You also help the system have a reality-based version of who this person is. A lot of times you can improve the humanization of everybody and then create a good discharge plan. This is what I call a bad discharge plan. There are studies now to show that street medicine consultation services can decrease the length of stay in hospitals and the readmission rates. Once you start being aware of what's happening on the street organically, because you're consistently going out, you begin to understand what the needs are at a grassroots level. The need for Narcan, the need for other services, ways to replace IDs. In 1993-4, Pittsburgh had a winter of minus 20 degrees for 11 nights. And we took over a building and we started our own low barrier winter shelter, which we run to this day. And it saved lives. But this is the fruit that grows from the roots, which are in the street. And you begin to get into larger and larger things like medical education, into housing, and all these things. But the key is that you're consistently on the street and maintaining the trust and your worthiness with the folks on the street. Students are a big part of what we do. I found that they're like a great crop that you can plant and harvest later. Nowadays in our hospital systems, many times I want something done, I can call the chairman, and they were a former street medicine student of mine, which it helps when you get a little bit older to have that influence. Many of our students have gone on to start street medicine programs, and they really bring an energy to it. And they then, I think, can go on to, even if they're doing different fields like surgery or whatever, they carry this sense of what it looks like from someone else's perspective. I think it makes all of them, nurses, doctors, social workers, whoever you're working with, really aware. The student in the middle, I'm really fond of. That's my oldest son, who's now a doctor. But it's a great classroom. It's fluid. It's nimble. It's real. I remember students say more often than anything, Dr. Withers, this is so real. I really love this. And one of the students a couple of years ago said, Dr. Withers, I got my common sense back this month. And so I think that the principles of this classroom of the streets, as we call it, really are something that we should look at in any number of excluded populations and other alternate realities that our systems don't meet. Medical schools, I think there's 35 of them now in the United States, 15 in development, do have access to street medicine. And there's a student group that's very powerful within our institute. Housing is another thing that you can do, and you could link it to street medicine. It's been shown very recently, as I suspected, that the street medicine relationship actually leads to a deeper penetration into the population and successful housing with people who are more challenged than most housing programs typically would be able to house. But not everyone makes it. This is a picture of Froggy I took years ago because I knew Froggy was not doing well, and I suspected that he was not going to make it. And sure enough, he did pass away after this. It's a tragedy. The folks that just die, sometimes their identity is never found. Our colleagues in Delhi actually identify the deaths of people experiencing homelessness by just unclaimed bodies. It's a tragedy that was really upsetting me that folks were just dying and no one was remembering them. The mortality rates, this is studied by Stephen Wong now in Toronto when he was in Boston. They followed 17,000 people for, I guess it looks like 5 years there. And there were 558 deaths, which is remarkable, just a tremendous death rate if you think about it. And the median death in that study was 47 of the folks that died. More recently, the folks in Boston did another follow-up study, Jill Ron Karate in Boston, and they found the death rate of folks experiencing homelessness, and they fortunately have like a monopoly. They can study folks in shelters and on the streets at the same time with a real large statistical power. They found that the death rate was 3 times that of the average person, but the folks on the street had a 10 times death rate. This is Bill, and I took a picture of Bill after getting his permission. But initially he said, no, I don't want you to take my picture. And I said, well, why not, Bill? And he said, well, because I've been in your office and all the people on the wall are dead. And he was right. I feared for him. Talked him into this photo. And the week after I took this photo, he died. And so around 1996, I was angry. I was upset that the deaths were just happening and no one was remembering folks. And so I got a donation, a generous donation from a person. And I said to Mike, my partner, I know what we're going to do with this money. We're going to buy plaques and we're going to just put, we remember, and then the name or nickname, and then the year that they died. And then we would just put them wherever that person died. If it was on the sidewalk, we'd do it there. If it was under a bridge, we'd do it there. It turned out the police wouldn't let us do that. So we went to the mayor's office and they said, well, we could give you a wall. And so we have a memorial wall in Pittsburgh. It's rather sacred ground for us. And we record the names of the people who have passed away on the street. And one of our nurse volunteers and I put this plaque above, which says, in memory of those who lived and died on our streets, we believe you're no longer cold, hungry, lonely, or frightened. May you watch over us from a warm, caring home above. And this really has become a very special place for all of us, including the folks on the street. And every year on December 21st, National Homeless Memorial Day, we have a memorial candlelight service for the folks that died. It's a powerful moment for us to remember the good things, the strengths of the people that we lost, and to dedicate ourselves together for not letting this tragedy continue if we can possibly help it. So that's Operation Safety Net. I'm so tempted to show you my international work. I've traveled around the world. There's a grassroots movement of around 200 programs on different continents. What the heck, I'll do it. I'm going to run through it. So the street medicine movement, when I started, I hadn't heard anyone doing this. It didn't have a name. I ended up in India in December of 93. And I heard about a doctor in Calcutta who was doing this work. And so I was excited and I went up to Calcutta. I got to meet Mother Teresa briefly, and then I got to meet Jack. And Jack Prager had been working on the streets since 1979. He just retired 2 years ago at the age of 90. But to see his work was an epiphany for me because he was dealing with so many of the same logistical issues with law enforcement, with the community, et cetera. It was like finding another person from the same planet. And at that point, I realized that this was a field of medicine and that I would dedicate myself to talking to folks like yourselves or anyone who shared a concern and wanted to try to do this kind of work, because it was a human right that anyone sleeping on the streets ought to have someone coming to them in a number of ways, but certainly addressing their health care in a way that would meet them where they are. Then I learned about Jim O'Connell and his group in Boston. Others began working, like Jack O'Hanley in Columbus. This is Seamus. I was making rounds after Katrina in New Orleans. He went on to become a doctor. This is Andrea in the Czech Republic. This is Isaac's wife when I was in Nigeria. And so it's been exciting to see the humanity of people, regardless of race, religion, or anything. We share this concern for the people that are excluded. And it's been an enormous unifying thing to have that shared vision, which many times in our own cities makes us feel like outsiders. But when you find other people who believe in this work, you don't feel alone. And so to pull that together in 2005, I created the first symposium. I had to give it a name, so I called it Street Medicine. We had 3 folks from outside of the States, so we called it International. There was only 17 people from out of town. It was a wonderful beginning. And we have an annual meeting, which will be virtual this year. We have posters, we have students. The attendance is usually over 500 now. Incredible future leaders get together. These are the cities where we've been. Next year will be Toronto. I'm excited about the Student Coalition, which has created its own forum. Here they are meeting for the first time in 2017. We have a fellowship. Last year, we had Dr. Cole, who's over in Milwaukee, and Dr. Kotov is our current fellow in street medicine. This is our network. growing fast. And this is our institute. And that's the symbol I mentioned before of the kneeling and the respect, which I think symbolizes what we're about. That's our website, streetmedicine.org. I always have to give credit to the Sisters of Mercy who have supported our work here in Pittsburgh forever and a day. They were walking the streets back in 1843, so nothing new to them. Lois says thank you, and so do I. At this point, I'm very happy to entertain any questions that you might have, and I do appreciate your attention.
Thank you, Dr. Withers. This is Ashok Patel. One of the questions that came through the chat is, in your 20 years, have we moved the needle to improving safety and access to homeless services?
Well, it's been 30 years. I think we've made progress, but it's slow. And to me, philosophically, it's organically linked to deeper issues of identity, exclusion, us and them. It intersects, of course, with race and historical injustice and just system-centered thinking. A big step forward was in the late 80s when they created the National Healthcare for the Homeless Network, and that brought healthcare into mostly shelters and soup kitchens. But with a few notable exceptions, it did not bring much care under bridges and into abandoned buildings. So the street medicine movement is kind of a second wave, and we're gaining a lot of momentum there. I think inclusion is becoming a model. It's a Great Britain model. One of our colleagues in London and others, and a few inclusion leaders are beginning to emerge here. It's just looking at systematically the dynamics and the mechanics of exclusion, and then the same with inclusion. So the folks experiencing street homelessness are one of any number of groups to look at that way. So when we change that perspective, I think we're going to create not just parallel pathways for folks in need, but a real sense of integration and inclusion into the health system. But it's like rebuilding your airplane while you're flying it. It is very difficult. I think just recognizing the unique suffering and mortality rates of people on the street is just beginning. And I'm hoping that'll lay the platform for more support of all kinds of services that go right where people are and begin where they are, be that addiction services or any number of mental health services. I would die happy if there was a street psychiatry field for people curled up next to dumpsters experiencing mental health problems. But we have to flip the script and say healthcare isn't just inside of buildings at our convenience. It has to be woven into the fabric of our communities. So street medicine is an example of how that might happen. I feel like we've been at this before, but we're definitely at a point where our very profession is at stake, the soul of our profession. It's being eroded by system-centered rigidity, by fear, by other motivations, which we're losing if we don't fight for. And so for me, the folks on the street are my heroes, and they've allowed me to recapture some of my own humanity and ground myself and teach in that context. So I'm eternally grateful for my brothers and sisters on the street.
Dr. Withers, we have a number of students here who are interested in getting involved with street medicine. And we had a bunch of questions asking, what are some high leverage actions that medical students and physicians and other providers can take to start street medicine here in Rochester, and also to connect with your organization?
Great. On the streetmedicine.org website, there's a student coalition of the brightest young people I've ever known, energetic. They've gone past our regular board by a couple miles in terms of all the things that they've been able to accomplish. So I would say that connecting with them is probably the first step. Dr. Dave Deasy, he's a retired dean in Madison. He's our go-to person for the beginning of how to start a street medicine program within an academic institution. I have a fair amount of experience with that too, but he's the guru of that. So you'll find friends and mentors in that as well. Honestly, there's a manual on how to do that, but it starts with a core group, an interest group that begins to say, we're dedicated to this vision. Oftentimes, quickly thereafter, a faculty champion, one or two or three, who are behind the idea, ideally, maybe one of whom would be willing to be on the street with you. The best scenario is to find an organization in your city who you can come to and say, please educate us about your outreach work. And you probably should date around a little bit before you are either accepted or accept that group. But don't come in a way that says, this is our plans, any more than you would on the street. Say, is there any way we can help you? We do have this street medicine model in mind. And if it's like Detroit with an NSO, they embrace the students, and many other cities. As long as you start slowly and respectfully, they'll be happy to bring a few of you along, especially if you have a qualified clinician with you as a mentor. And you will then be serving the people that they love and care about. And that's kind of the slow, organic way that it can grow. And when it matures, it's a beautiful relationship. I would welcome students to contact Operation Safety Net. You can get me through the Institute for clinical rotations. We love working with future leaders.
Dr. Withers, we had numerous people curious about your team composition, how you decide who's on your team, and also what you carry with you. You showed us some pictures of one of your bags, and we could see some of the things that are in there, but people are wondering about what equipment to prioritize, if they're going to carry it on their back, what antibiotics you've chosen, how do you get access to those things, and some just logistical questions about operating in the field.
The teams should be, I always like to use the campfire analogy. You should research well and then start small with a little bit of tinder. You don't want to get ahead of your rights, which is given to you by the people on the street. So you want to start very small. So typically, with Mike and I, it was really good because he'd lived on the street and it was just the two of us. So that was really the best way to start. So I'd say start small. We don't typically take a team that's more than 4 or 5 people. There's always an outreach leader who is extremely familiar with the folks on the street. They know the different campsites. They know the dynamics. It's actually very similar to a really big, complex soap opera. You need to know the last 4 episodes and what was happening. So keeping the narrative arcs of people is really important before you just step into something. But typically we have an outreach leader. We have a lead medical person. That could be a nurse practitioner or a physician assistant, or somebody that's got a lot of well-rounded skill. If we can bring someone with case management skills, that's really good, who can follow up on the hot mess that you might have uncovered to help people go to the next step the next day. And then we always have 1 or 2 learners. We have a street medicine fellow with most of our teams now. So that's typically it. You can go with a slightly larger group, but then you have to use what I call the slinky model, where you send the trusted people in and then ask permission if the others can come. You have to have someone watching to make sure there's safety. There's never been anyone harmed physically doing this work that I'm aware of, or any of our network are aware of. There's never been anyone sued for malpractice doing street medicine, but any of those things could change tomorrow, tonight. And so we do not take those things for granted. You need someone with a heads up thing that can maintain the safety and the relationships. There are different settings. The streets tend to break into 2 settings. One is the people you have to crawl under bridges to find. The other that you maybe have a location that they come to, like a park or a medical van. And so that has a different strategy. And then there's another strategy that people use where they have maybe a park and they set up tables and they have stations, almost like a disaster response. There's plans for all of those things, and I could talk to you guys in more depth. Let's just say that you learn very quickly. The streets teach you everything, and you have to listen to them and then listen again and again. You'll start off with just your blood pressure cuff and your stethoscope with your basic equipment. I have a otophthalmoscope, a glucometer, a pulse oximeter. We have had thermometers with us. And then we get into competitions with other cities that have everything up to ultrasound. That's a little over the top as far as I'm concerned. So basic diagnostic equipment, you're going to have a bag or kit or something that has wound care materials. You have to have something for aches and pains. You have to obviously clear the medical history before you give it. There's going to be a bag for antibiotics, and we tend to go with just the basic simple ones, PenVK for oral abscesses and Bactrim for staph and Z-Paks and such. You don't go too much beyond the basics. Antihypertensive bag, a bag with ointments, lotions and potions. There's a bag for odds and ends, maybe a prednisone dose pack, some seizure meds, et cetera, but keeping it within those bags. And I have a manual that you can look at if you want to see it that has suggestions for that stuff. I always have a few extra things in there. We have harm reduction things that another team member brings. We actually have a team that goes with us that has needles and other things that folks who are addicted need to stay clean in terms of their equipment. We have lots of Narcan. It's by far our greatest death right now is overdoses. And referral material, a headlamp, and I'm probably forgetting something critical. Every individual tends to customize their own bag. Sometimes they get pretty big.
We have over 100 participants on this call, and I just wanted to let you know the range of expertise and community commitment that is represented on the call. Then we'll maybe talk about how do you engage such a diverse workforce in developing a coherent and sustainable program. We have Mayor Norton, who loved your program and says thank you. She also created a proclamation for this special day. We have people from the emergency room. We have nursing and social services from the community like Salvation Army and others. So would you mind just sharing your insights as we want to start small and do this right? How do you engage all these different partners, and where do you meet them at before we go meet the people on the street?
Every city has its own unique stakeholder group and other factors, political, et cetera. And it's always an evolving story. I think the main thing is that nobody owns the street, as far as I'm concerned. But you do, for the benefit of the people you serve, you want to be as coordinated as you possibly can. I find it's better if you get together behind one street medicine program, but oftentimes you develop one or two or three even in a city, and then you have to have a regular forum to meet within confidentiality agreements to coordinate, which is what we do here in Pittsburgh now. As I said before, it's good to get to know the stakeholders. It's so overwhelmingly encouraging for me to see this kind of a stakeholder group. It says so much about your community and your city that you're interested and you're compassionate. I find that a city your size is like the sweet spot because you're not so big to be jaded and big enough, though, that you recognize the need and you do it together. I think that you have to remember that it's the folks on the street come first. You can have your plans and schemes, but you have to keep in mind as best you can that you're accountable to them and their dignity and if it's working. So healthcare for the homeless programs always have a consumer advisory board, and it's good to have some representatives with lived experience that can be part of the process. In most cities, there's a county group usually that has a continuum of care group, and we have different levels here of coordinating committees that meet. The highest level, of course, is organizing what's happening with the camps and evictions and, what are we going to do in terms of COVID and all these kinds of things. And that's a higher level group that's really responsible for the well-being of the community and particularly the folks on the street. And then you get down to typically the Department of Human Services. It's working with immediate issues that have to do with the well-being of the population. And then a smaller group that meets regularly to really focus on the medical services. So it is a little awkward, but you have to kind of keep communication going at these different levels. I do think that it's best to start small. And if you can agree that there's a core group that's going to do this, some of you may have to sit on the bench for a while or contribute in other ways. That particularly means groups of students and residents and such, because you don't want to overwhelm the folks there. If there is a lead agency that's really trusted that's doing street outreach now, they will help guide the best way to organically grow your street program. So it's a bit of an art form. If any of you in your leadership or otherwise want to talk to me, I'm pretty much always available to folks like yourselves. I'm just saying that because it gets complicated. Sometimes people love this work and want to get involved, but it creates tension politically between groups on the street, groups in different agencies and such. And there's always a good solution, but sometimes it's a knot that's a little difficult to untangle. That's the terrain of the evolution of a street medicine program.
We had a couple questions about burnout. So in a field that's highly demanding, there's always more work to be done. How did you take time for yourself and avoid being overwhelmed by all of the social issues that you're encountering every day?
Great question. To me, it's kind of like this secret elixir that being with folks in the intimate and very real environment of the street is rejuvenating and resuscitating. It definitely takes a lot of reflective time with each other to process what you're seeing, because you're going to see injustice, you're going to see suffering, hopelessness, but you're going to see strength and courage. And it gives you a sense of purpose that is possible, but difficult to get at this level outside of maybe international medical work. I think burnout for me and most folks that I know, we all tend to be a little bit ADD or something, I don't know, but we love being outdoors and being free of the white coat a bit. But the structural violence that we inflict upon our patients is also inflicted upon us. First responders and the police officers and others also get stuck at the edge of these difficult social issues with not having the flexibility and tools to actually just be a person. And when you're with someone next to the camp and you don't really have a heavy agenda for them and you can just be a person, that is so rejuvenating and rewarding. I can tell you some stories about that, which would really highlight it, but I don't want to take much more time. But it really is the opposite of burnout for almost everybody I know.
Dr. Withers, thank you so much for the wonderful talk and leading today's discussion. It's inspiring. We're getting a lot of thank yous in the chat to you, and I can't thank you enough. I also just want to briefly thank the Zumbro Valley Medical Society for sponsoring today's event, and just to recognize Dr. Beth Kangas, Dr. Ashok Patel, Grace Johnson, Mayor Norton. Thank you very much for helping us put this together and working behind the scenes to make this possible.